Today we're going to discuss on malaria parasite. Okay. Now malaria is a very important infection because in spite of it being one of the oldest infections known to mankind, uh, we are still dealing with malaria. We are not able to eradicate the parasite, though at some form we are able to control the infection. So today I'm just going to discuss with you regarding the parasites which are known to cause malaria. So as I've already mentioned that this is one of the oldest known disease infecting humans for more than 50,000 years. So when you look at the references regarding this parasite, okay, it has been recorded since many years. However, though the infection has been recorded, but what is the entity we have to know about the infection is how the infection is transmitted. What are the parasite, what are the vectors which are responsible for the infection? So in the year 1880, the first advance in malaria was made by a French army doctor whose name is Charles Leverin. He was the first person who actually examined the red blood cells and discovered the parasite. So this was the first time where it was discovered that the parasite is was known as a causative agent to cause this disease. Then in the year 1898, Ronald Ross, I think most of you would have read about the achievements of Ronald Ross. He was the person who discovered that actually the vectors, mosquitoes, were responsible for the transmission of malaria. So subsequently, what happened is we have discovered that we know that the parasite can be demonstrated in RBCs, and we knew that the mosquitoes were the vectors which are known to cause malaria, or rather to transmit the infection which we know as malaria. The next step is we have to find what is the cure. Since we have an infection, we have to find a cure. So similarly here again, when you look back, you look back the history, the first effective medicine has been discovered by Pierre Pelletier and Joseph Covento. These were two pioneers who actually discovered this medicine which you call as quinine. Quinine, most of you would probably have heard about this anti-malarial drug, a very effective malarial drug. So this was one of the most robust type of anti-malarial drug which have been used for the treatment of malaria. Now the organism per se, this is a protozoan. If you know the classification of in parasitology, we have the classification where we divide the parasites in protozoans and helminths. So this belongs to is a protozoa, and the genus Plasmodium. It contains many species, but of all these species, there are 5 very distinct species which are known to cause human infections. You have Plasmodium falciparum, which is responsible for the type of presentation which we call as malignant tertian malaria. We have Plasmodium malariae, which cause benign quartan malaria. Plasmodium ovale, which is tertian malaria. Plasmodium vivax, benign tertian malaria. And Plasmodium knowlesi, which is known to cause quotidian malaria. Now, Plasmodium knowlesi has been a new entity which has got the interest of the scientists worldwide, because this was a parasite which has been discovered very quite recently. It was first discovered in Malaysia when they examined the archive slides of people who had been suspected to have malaria. At that point of time, uh, these infections were reported as caused by Plasmodium malariae, but subsequently, with advances in technology, they realized that this is a totally a different entity which is not similar, which is not the same as Plasmodium malariae. So this name has come up, so that we know as Plasmodium knowlesi. So this is a new species of malaria parasite which has been recently discovered. So as far as your knowledge is concerned, please remember you have 5 very distinct groups, distinct species of Plasmodium species which are known to cause human infection. And as you know that we've already, I think most of you would know that Plasmodium malaria is basically transmitted by the mosquitoes. So here you can see that Plasmodium parasites are highly specific with female Anopheles mosquitoes. So this is a species of the mosquito which are known to cause a transmission of the malaria. So besides that, you have other species. Culicifaces, Stephensi, and Fluviatilis. These are some of the other known species. These are some of the species which are known to cause transmission, responsible for transmission of Plasmodium or malaria. Now here, this is a world map showing you the distribution, the global distribution of malaria. We are actually not free from malaria in toto, but in some areas, if you look at this world map, you can see that some areas where malaria is not known, some areas where, as you mark here as yellow, where malaria is there, but in some parts like in India, we have some parts which you have malaria. It's not that malaria is present all over the country. So similarly, when you look at the world map, you can see some continents. You have some areas where malaria is known to occur in some specific areas. Then you also have some areas where malaria is known to occur throughout, where you have a lot of cases of malaria. So if you look at this world map, you can see, you can see here your South America, then you can have Africa. You can see most areas in South Africa. Most of them have got, rather you can call it as endemic areas where you can get malaria. India per se, that way we have, though malaria is there, it's not presented, it has not been reported from all parts of the country. So when you talk about the epidemiology of the parasite, there are certain features you have to remember. Why in some areas you have malaria, some areas you do not have malaria, and in some areas the infection is it's highly prevalent. So these are some of the predisposing factors. You have density of the vectors and the number of human bites. This is again very important. How much density of the vectors, which means how much of the malaria, the Anopheles mosquitoes are prevalent in the area. Then the time of the mosquito bite. So what time the mosquito bite? Is it in the early morning, it's in the morning, or in the evening time? And mosquito longevity. This is again related to the lifespan of the mosquito, because as long as the mosquito is alive, and if the mosquito is harboring the infective form of the parasite, they will keep on transmitting the infection. So this is again one of the predisposing factors. And the optimum temperature. What is the temperature which is responsible? Usually less than 30 degrees with humidity, rainfall. These are some of the parameters which render the infection to be more prevalent in certain geographical areas. Here, if you see, this is maybe 2019 statistics. As much as 228 million people get malaria each year, and it kills 4 lakh people per year. This is a worldwide statistic. So if you look here at 40% of the world's population, they live in malarian zones. Now when you talk about malarian zones, there are some definitions which you have to be familiar. You have something which you call as hypoendemic, mesoendemic, hyperendemic, and holoendemic. So these are basically dependent on how much is the transmission rate of the infection. Okay. So when you talk about the malarial zones, if you see here, 95% of the malaria zones is in Africa, of which we again have in Southeast Asia we have 3.4%. Now Plasmodium falciparum, of all the 5 species of Plasmodium, you have Plasmodium falciparum. This is one of the commonest species which is found worldwide. Now when you talk about Plasmodium vivax, in Southeast Asia, this is the most important species of the malarian parasite, which has been reported from Southeast Asia, which contributes as much as 53%. And of this 53%, 47% of this infection is from India. Now in India, we have certain endemic areas. We have the Northeast, then we have Odisha, Jharkhand, and we have Chhattisgarh. So most of these areas, most commonly we have the Plasmodium falciparum, which is one of the common parasite which has been reported. However, after this, what happened in Uttar Pradesh, we had a surge of cases of Plasmodium vivax. So in UP, we have these cases. So now actually most of the times you will have cases of, in those areas you have most cases of Plasmodium vivax. But all said and done, you might have a combination of both Plasmodium falciparum and Plasmodium vivax, because the migration of people from one area to another is very high in the present scenario. Though in the present scenario, because of COVID, people are staying in their homes, but if you look at migration of people from certain areas might migrate to certain parts of the country. So we cannot say that the parasite is only restricted to some particular area. Because of human migration, the parasite can be transmitted, can be transferred, or can be presented in some other areas because of human migration. Now regarding Plasmodium malaria and Plasmodium ovale, few cases have been reported, but they are not, most of them, they are not very prevalent in India. Now regarding Plasmodium knowledge, we have not, I don't know, at least we have not seen any cases of Plasmodium knowledge which has been reported from India. So in a nutshell, what you can say is that at least in India, most cases which have been reported is because of Plasmodium falciparum and Plasmodium vivax. Now the life cycle of this parasite. Now this parasite, if you look, I've already mentioned, you have a mosquito, which is a very integral part when you talk about the life cycle of the parasite, because without the mosquito, the infection definitely will not be there. So the life cycle is usually completed in two hosts. You have the definitive host, which is the female Anopheles, which has the sexual cycle, or what we call it as porogony. So this is sexual cycle which takes place in the female Anopheles. Now this is, please remember that when you're talking about parasitology, we always use this term definitive host, intermediate host. So when we're talking about definitive host, basically we're talking about the ability of the host to have a sexual cycle. And when you're talking about intermediate host, which means the asexual cycle takes place. This is one of the parasites where you see here when you're talking about man. Man here is not a definitive host. So this is one exception, because if you look in parasitology, you will see that humans are always, most of the time, the definitive host. So this is the exception here in case of malaria. You can see here that humans are actually the intermediate host. So when you're talking about parasitology, again you have the definitive host, you have the intermediate host, you have two hosts. Now between the intermediate and the definitive host, what is the intermediate form of how the infection gets transmitted from the intermediate to the definitive host, or otherwise versa? So what happens here? As you can see here, we have something which call as the infective form, because unless you have the infective form, the infection will not be successfully transmitted from the definitive host to the intermediate host. So here in the case of malaria, we have the sporozoites, which are basically the infective form. So the modes of transmission, most times most of the time the infection is usually transmitted by the bite of the female Anopheles mosquitoes. Though some of you must be wondering why only females are responsible for the transmission of the infection. Males mosquitoes, this is a part of probably of epidemiology, which probably will be taught in community medicine, but in a nutshell, what happens is males usually do not require a blood meal. So that's why they are not responsible for the transmission of the infection. They can survive eating juices of vegetations. So unlike in the case of a female Anopheles, where they require a blood meal for them. So that is why female Anopheles mosquitoes are actually responsible for the transmission of the mosquito. So most of the time you will see the common mode of transmission is by the bite of the mosquito. However, there can also be some other modes of transmission, which can be in the form of blood transfusion. If a person donates blood when he's having malaria, that's why you see when you give blood transfusion, if any one of you is a blood donor, definitely they would have asked you whether history of whether you've had fever in the subsequent before you give your blood transfusion 2 weeks, if you've had any infection. This is because we want to rule out some of the infections which can be transmitted via blood. So blood transfusion is one of the other modalities where the infection can be transmitted, or sometimes, infrequently, from the mother to the child, the parasite can also be transmitted. But here, if you look at when you look at the infective forms of how the mode of transmission which can be transmitted from blood transfusion of placenta, it's not sporozoites, but it is the merozoites. So when you talk about the life cycle is again divided into many stages. You have something which you call as, I'm talking about the human cycle. I'm not going to talk about what happens in the mosquito. I'm more interested in talking about what happens in humans. So let us concentrate on what happens actually in humans. You have something which you call as the erythrocytic schizogony. So we have the exoerythrocytic stage. Okay. Then we have the erythrocytic schizogony. We have gametogony. So in the mosquito, what happens? I will just tell you. In mosquito, this is what happens. You have exflagellation, then zygote formation, which will be, because in the mosquito you have this sexual cycle. So these are some of the sexual forms of the sexual, the major sexual forms of the mosquito develops in the mosquito. So exflagellation, then it forms zygote, ookinete, oocyst, and then finally the sporozoites, which are the infective forms. So these are the forms which, after going all through these developmental stages in the mosquitoes, the end point of the mosquito which it produces is that the sporozoites are present in the mosquitoes, and these are the ones which is actually which is the one which is transmitted to humans, so that all these stages in the human cycle takes place. So this is what I've told you. You have the mosquito, a female Anopheles mosquito. Okay, it can bite at many sites. There's no specific site for which mosquito. It doesn't have any preference. It can bite at any exposed area in the body. So as I've already told you, that the infective form, because as it undergoes the developmental stages in the mosquito, the end point is that the mosquito has to have the sporozoites, and this is what is actually transmitted in humans. So you have these sporozoites, which is transmitted to the bite of the mosquitoes. So this is what happens. Okay, so it goes to the liver, and I will go subsequently. We will see what happens as the parasite enters inside the body. What are the developmental stages it undergoes and at which sites? So this is what I've already told you, that the sporozoites enter into the bloodstream. So for some time they will be there in the circulation for probably maybe 30 minutes, and immediately after that circulation it enters inside the liver. So then starts the next stage. Then you have the pre-erythrocytic stage. Okay, so this is also called as the tissue or hepatic stage, because after 30 minutes the parasites enters inside the liver. So the sporozoites which have been injected by the mosquito, they mature into the schizons. Now schizons, as it develops, what happens is just like, it's like a spherule, it's just like a cell. Okay, so what happens once it develops into a schizon, the stage happens there, when the parasites keep on multiplying, the schizons is not able to contain the number of sporozoites, the number of the merozoites which have developed inside the schizon. So it bursts, and then it releases what we call as the merozoites. Okay, so the other differences you have to remember here is, in the case of Plasmodium vivax and in the case of Plasmodium ovale, the schizons, though it developed from the schizons, the other stage inside the schizons, what is released is the merozoites. But in these species, the ability of the schizons, it can also produce something which we call as hypnozoites. Now these hypnozoites are the other dormant forms of the parasites which resides in the liver. They resides in the liver for many, sometimes months, even years. And these are the stages of the parasites which are known to cause, or which are responsible for what we call as relapses in malaria. So relapses in malaria, as what you see here, is seen because of the dormant forms of what we call as the hypnozoites, which is commonly seen in cases of Plasmodium vivax and Plasmodium ovale. This cycle does not happen if it is Plasmodium malariae or in case of Plasmodium falciparum. So this form of cycle, hypnozoites, the formation of hypnozoites is only seen if the infection has been caused by Plasmodium vivax and Plasmodium ovale. Now then, after that what happens is, as I've already told you, you have after the hepatic site or the pre-erythrocytic site, you have the asexual cycle or what we call as the erythrocytic schizogony. So what happens now? The parasite has gone to the liver, it has formed schizons, and from the schizons we have the merozoites. Now the merozoites, as I've already told you, in the case of Plasmodium vivax ovale, it will form hypnozoites. Some of them will be released also in from the liver. And where will it go? Next stage is RBCs are there. So the merozoites, they invade the RBCs. So here in the RBCs, they convert, they mature, and they grow into various stages. And you can see the stages of the malaria parasite. So this is actually the stage which we commonly demonstrate in the peripheral blood smear. Most of you must be would have been aware about the diagnosis of malaria. We demonstrate the malarial parasite in the peripheral blood smear. So what actually are we looking when you look in the peripheral blood smear? These are the stages which we look, because once it goes into RBCs, the parasite doesn't remain dormant. It keeps undergoing different morphological changes depending on the species. Okay, they grow and they mature. So the stages which you commonly see here, what you call as the trophozoites. Now trophozoites, how will you know that it is a trophozoite? So this is the morphological appearance of the trophozoites. They can appear as ring forms. Probably when you talk about diagnosis, you will be demonstrated of how a peripheral blood smear looks. When you're talking about diagnosis of malaria, how will you differentiate whether what you're seeing inside the RBC is actually a parasite or not? Because as most of you pathology, you would have seen a normal peripheral blood smear. Usually when you look at an RBC, the surface, nothing is there in the, when you look at an RBC, a normal RBC, nothing is there in the RBC. But if you're talking about malaria, you will see some morphological forms which is not expected. So those are the forms which you have to actually identify to say that the person is having malaria. So these are the forms which we actually look. So the trophozoites, which can be either early trophozoites or late trophozoites. Now the trophozoites, what happened next stages? Again, they develop into the schizons. Now, as it multiplies in the RBC, similarly it becomes a schizon. Then the schizons, as you know, because it's an enclosed space, so if there are too many trophozoites within the schizon will not be able to contain these parasites, so they will burst and then they will release again what we call as merozoites. Okay, and these merozoites, what they will do is they will not die off as they are released from any specific RBCs. The tendency of these merozoites is that they will keep on infecting more RBCs. Okay, so that's why you will have more RBCs which have these forms of the parasite. So the release of the merozoite, this is again very important when you're talking about diagnosis of malaria. When a person presents to you with malaria, most of the time you will see the person, typically if a person at all has typical signs and symptoms, they will present to you with fever, chills, rigors, and other symptoms. Okay, but most frequently if a person is having malaria, these are not some of the specific signs: fever, chills, and rigors, and these have been correlated with the release of the merozoites from the RBC. Whenever the RBC is, because when you're talking about RBC, it's not only one RBC which is infected. Here we're talking about thousands of RBCs which has been infected. So if at some particular point a number of RBCs, they release the merozoites, so this is what is actually what do you call it? You can correlate the fever or the chills and rigors is often associated with the release of the merozoites from the schizons, which is there in the RBCs. So this is one form of how you can actually say that the person is, when he's having fever, you can actually time. That's why we have those terms. If you remember, we have tertian malaria, quotient malaria, benign malaria. All those terms have actually been classified because of these kind of signs and symptoms. Then we have the sexual phase. Now the cycle as it progresses. So You remember, you have a sporozoid, it has gone inside the liver, it has formed the schizon, and from the schizon you have the merozoites. Merozoites has gone into the RBCs, again it has formed schizon, and from there again you have your merozoites. So some of these merozoites, okay, as I have told you, merozoites, when they release some of the merozoites, they get retained in the liver and become hypnozoites. Now some of these merozoites goes into RBCs. Now once it goes into the RBCs, there's another form of the the form of the cycle which can also occur in humans. Though all this while I keep mentioning, when you're talking about trophozoites, this is the asexual cycle of the parasite. But some of these merozoites can also undergo the sexual cycle. They can convert into a male and a female gametocyte. Okay. So these are again these are the forms of the parasite which are again responsible, whereby if a female, if you have a mosquito which bites a human who is actually carrying these sexual forms of the mosquito, this is where the cycle starts again in the mosquito. So most of the time, if you have these form of this cycle where you have the sexual phase, where you have the gametocytes, so if these gametocytes are taken up by the mosquitoes, as I've already told you, that the mosquito, once it enters inside the mosquito, sexual phase is the one which happens inside the mosquito. So once the mosquito, if it happens to bite a person, a human who has these forms, the gametocytes, so what happens? These male and female gametocytes, they can fuse, form an ookinete. Okay, this takes place in the gut lumen of the mosquitoes. Then the ookinete again converts into the oocyst. Oocyst again release the sporozoites, and sporozoites, if they're they release inside the mosquito, they get transmitted or they migrate to the salivary gland of the mosquito, and then this mosquito which has ingested the blood having these gametocytes from human, they will release the sporozoites. So this is how the cycle takes place in the mosquito. So I hope this is in a very simple way. I've just told you about actually the life cycle in the mosquito. So in a nutshell, what happens? Please remember, you have a mosquito having the sporozoites. It bites. It bites a human host. So the sporozoites are released, goes inside the liver. Okay, this is the pre-erythrocytic stage. So once it goes into the liver, it converts into the schizon. Inside the schizons, you have merozoites. Some of these merozoites get converted, what we call as the hypnozoites, which is seen in case of malaria ovale and malaria vivax. And these are the ones which are responsible for relapses. Okay, so some of these merozoites get released and it goes to the RBCs, and in the RBCs it undergoes an asexual form. So you can see all the cycles. You have the trophozoites, and then finally again it converts into schizons, which further releases the merozoites, which can affect more RBCs. Okay, so this is a continuous cycle which can go on, and when it talks about the asexual cycle, the merozoites keep on infecting the RBCs, and more RBCs gets infected. So subsequently what happens, some of these merozoites have the propensity, or they have the ability to convert into the gametocytes. So you have the male and female gametocytes which can be present in the RBCs of certain humans. Now if a mosquito bites a person who harbors these sexual forms, okay, once they take the blood meal from these individuals who harbor these sexual forms, if they ingest gametocytes, then this is the cycle which will happen. Inside the mosquito, it converts, they will fuse and they can form an ookinete. Male and female gamete will fuse and they will form the ookinete. Then they form the oocyst, and this release from the oocyst, you get this, the sporozoites in the mosquito, which migrates into the salivary glands of the mosquito, and from there on, the next cycle goes on if the mosquito keeps biting another unsuspected human host. I hope this is clear. Whatever said and done, there are certain, when you're talking about malaria, it is not that everyone who has been bitten by a mosquito gets malaria. Okay, there is definitely, all of us would have got bitten by mosquitoes, but all of us do not land of malaria. Sometimes there are certain conditions which protects the host from having the clinical manifestations of malaria. Some of these are well known, like in the case of red cell and hemoglobin variants. So these are well known examples of because of genetic makeup, inherited factors which protect humans from malaria. So you can have hemoglobin S, certain thalassemias, or a person who has G6PD deficiency. These are some of the genetic factors which actually prevent these hosts, these humans or these individuals from getting malaria. Okay, so these are some of probably when you talk about the other manifestations of having these kind of conditions is harmful, but in some way they are protective because they will not be able to get malaria infection. Then you have something which you call as the Duffy blood group. So Duffy blood group is actually one of the important Duffy blood receptors are actually important receptors when you talk about Plasmodium vivax because they require these form of receptors to enter the RBC. So if a person is having deficiency of these receptors, then those kind of individuals will become resistant to this form of species of malaria. This is actually can be explained the rarity of Plasmodium vivax in Africa. Okay. The naturally acquired immunity. So people who are constantly exposed to malaria gradually acquire immunity, firstly against the clinical form of the disease and later against the parasite infections. Okay. So if you remember, I've mentioned those terms which we call as holoendemic, mesoendemic. Okay. So this is what we actually has been observed that clinical manifestations of malaria are more severe in the non-immune areas. Okay. So when you're talking about malaria, there are a lot of complexities when you talk about transmission dynamics of malaria. It's very safe to say that you have mosquito and you have humans that easily they can transmit. But you have all these other factors which do also have a role to play whereby some areas they do not have malaria in spite of having vectors, in spite of having conducive environmental conditions where it should be feasible where you should have a lot of cases of malaria, but then it is not so because there are certain other factors which come into play when you talk about the transmission dynamics of malaria. Then you have something which you call as fetal hemoglobin HbF. So high levels of HbF usually occurs in neonates and in some individuals who has this inherited inherited hemoglobin variant. These are again protected against severe form of Plasmodium falciparum malaria. So if you look here, you have many genetic factors which also have a role to play when you talk about why some individuals get malaria, some do not get malaria, because these are some of the factors which also we have to consider. Now regarding the pathogens and clinical features, this is when you're talking about a benign form of malaria. So you have a triad which is consistent with which is usually present as a fever, anemia, and splenomegaly. So most of the time the incubation of malaria is usually between 9 to 14 days. And as I've already mentioned that most of the time the common signs and symptoms will be fever, chills, headache, backache and joint pain. And sometimes it might be associated with gastrointestinal symptoms in the form of nausea and vomiting. So okay, you can have this form of, you can look at this picture, you can see this lady, she's feeling very cold because this is very common. When you're talking about malaria, you will have typical signs of fever and chills and rigors. You can see really the person is having chills, the person is having chills and rigors. So the classical attack of malaria usually lasts 6 to 10 hours. Okay. So the cold stage, I told you, you have fever, you have chills and rigors. So these are the stages. You can have a cold stage, sensation of cold. You can see a person is having so much shivering. Then you can have the hot stage, fever, headaches, okay, which is, person will be feeling very hot, okay. So at one stage, person will be very cold. You will cover the person with so much blankets, giving everything, making sure that the person is feeling warm. After some time, you will see the person is feeling very hot. Okay, so this is a stage. This is just to show you what actually happens when talking about malaria. Sometimes in children, this is very particularly very important in children. Though we talk about fever, we talk about chills and rigors, these signs of symptoms will not most often of the time be presented in children. Children sometimes present with atypical stages, signs and symptoms. So in children, most of the time they can just present you with vomiting, or sometimes they can present with seizures. Okay, and the temperature, usually when you talk about fever, it usually goes up to 104 degrees Fahrenheit. So what happens now? At one stage you will find that the person is feeling very cold. After some time the person is feeling very hot. Then you will have another stage which we call as a sweating stage. So person starts sweating. Okay, he will start sweating. So after you find that the person is sweating so much, you will look at the temperature. Temperature again has come back to normal. But again, the person will have a lot of fatigue, lot of tiredness, which is a normal occurrence which you see in case of fever, in the case of malaria. Now, paroxysm, this is what we call, no? Sometimes person having cold stage, hot stage, sweating, these are all associated, which I've already mentioned, when the Shillong bursts from the RBCs, when the Shillong burns and it releases merozoites. So this is what is associated with the paroxysm. Okay. So whenever there are a lot of RBCs which has burst and released the merozoites, this is what you will see associated, coinciding with the paroxysm which you see in case of malaria. Now, when you talk about tertiary malaria, paroxysms of malaria is repeated after 48 hours of fever occurring every third day. Okay, and this is what is commonly seen in case of Plasmodium falciparum, ovale, and vivax. If you remember when your clinical posting, if you look at the patient's chart, you would definitely have seen something which you call as a temperature chart. Now, what is the role of a temperature chart? If a person is having malaria, if you regularly, consistently note the temperature of the person, you will find, and if you plot all the graphs, you will see this is the picture which you see in case of tertiary malaria. Now, if you're talking about quaternary malaria, this is the picture you will see. If you plot the graph, every day you keep on taking the temperature of the person. If you plot the graph, this is the kind of picture you will see. So a temperature chart which is put in the patient's case sheet. Okay, if most of you have actually gone, if you have seen this temperature chart which is there always with the patient in the patient's case sheet, where the nurses record the daily temperature. So if you plot the graph and if you look at the pattern of the fever, you will see this is the pattern which you see in case of malaria. Okay. Even in case of enteric fever, we have a very typical form of, the fever, the step-ladder pattern, which you call in case of enteric fever. It is very, very typical. So just a very simple, test, which if you observe it properly, might be having some clue as what is the cause of the fever and what type of fever the person is having. If you just do this plotting of the temperature charts. Now the pathogens and clinical features of falciparum malaria. Now coming to some species of plasmodium species. Some of these species of malaria parasites have associated with a lot of complications. So some of these complications most often are associated with Plasmodium falciparum, and some of these features are usually very acute, severe. Okay, so in the case of Plasmodium falciparum, there is a term which I want all of you to remember. We have something which we call as sequestration. Now, sequestration is basically the ability of the parasite to sequester deep venous microvasculature, which is mediated through the process of cytoadherence. Now, this is a property which is only seen in case of Plasmodium falciparum, and it is because of this ability of sequestration we have lot of those complications which we often associated with cases of Plasmodium falciparum. Otherwise, if Plasmodium falciparum is like any other infection, we will not be so much concerned. But the problem is because there are other features associated with this parasite. It has ability to cause a lot of complications mediated by some of these mechanisms. One is sequestration. Okay, cytoadherence. Now, cytoadherence. Now, this Plasmodium falciparum has something which you call as the PFEMP1. So this is basically an antigen which is there in the parasite. So what this parasite does is, once this parasite attaches, okay, it affects an RBC. Now, because of this, the parasite which is there in the RBC, the whole morphology, the whole function of the RBC is totally deformed. So these parasites, these RBCs which are actually carrying the parasite, they become more sticky. So sticky means they can adhere, they can easily adhere into the basement membrane of the endothelium of the endothelium lining the blood vessels. Because when you're talking about RBCs are usually present in the in the blood cells, okay, in the blood vessels. So what happens is, when these parasites infect the RBCs, these RBCs are not as normal RBCs where they were flowing. In a normal RBCs, if you look at you look at the blood cells, you look at the blood vessels, you will see RBCs will easily flow. But because of the presence of these parasites inside these RBCs, now these RBCs become they become ineffective, or they become defective, whereby they can easily adhere to the endothelium of the which is lining the blood vessels. So what happens as a result? If there are so many of these RBCs lining the endothelium, what will happen? A stage will come where there will be clogging. So the lumen of the RBC of the blood vessels gets occluded, because there's so much of these RBCs which are very sticky. They tend to stick to the endothelium of the blood vessels. As they keep, so more blood vessels keep on attaching one by one. At some point of time, what happens? There will be a stage where the whole lumen of this blood vessel is occluded, because these blood vessels, these RBCs, which are defective by virtue of the presence of the parasites, they occlude the lumen of the RBCs. So what happens? If you have a major blood vessel which is supposed to supply, the blood flow is supposed to go to some highly critical areas, what happens? The blood flow will not be there. Blood supply will be totally cut off to those areas. Okay. So what happens? This is what we use the term cytoadherence and rosetting. Okay, so the RBCs keep on accumulating because they are not free flowing, because of the virtue of the parasite which is inside the RBC, rendering them more sticky, whereby they can keep attaching to all the RBCs or to the endothelium of the blood vessels. So occlusion can occur. Suppose you just imagine, if this RBC is the blood cells which is going to supply vital organs, then what happens if the blood supply is not supplied, is occluded to those vital organs? There will be definite lot of consequences. So this is just to show you the schematic diagram of the PFEMP antigen which is there in the case of the parasite. So rosetting, this is what we call as rosetting. Normally, when you talk about RBC, even if you look in a peripheral blood smear, you definitely do not see clumps of RBC attaching to each other. But in the case of this, what we call as rosetting, you will see clumps of RBC. They have because the main morphology, the normal function of the RBC is totally destroyed, totally disrupted by the presence of the parasite which is inside the RBC. So they can have something which you call as rosetting. So the RBCs will tend to adhere to the endothelium lining the blood vessels as well as to each other. So this is what we call as rosetting. You can have something which again call as clumping. Then you have sometimes deformability. You can see once the parasite is present inside the RBC, the whole structure of the RBC becomes totally deformed. So what are the complications of falciparum or Plasmodium falciparum? Most of you would have heard of this term which we call as cerebral malaria. Besides that, you have something which we call as pernicious anemia, which is associated in the form of black water fever, algid malaria, or sometimes you can have septicemic malaria. Sometimes you can have something which you call as hyperglycemia, which is often again a complication of Plasmodium falciparum, ARDS, certain coagulation abnormalities, and most often, okay, These are some of the untoward complications which is often associated with Plasmodium falciparum. Person goes into cardiovascular collapse and then shock. This is a cerebral malaria. Okay, so this is defined as an arousable coma persisting for more than 1 hour. Here, when you do at this point of time, if you take, if you take a proper clinical history, and then you ask the person whether he has come from an endemic area or not from an endemic area, whether he has traveled to certain endemic. So history taking is very very important. But if you take, you take a blood sample, you take a blood sample, and then if you do peripheral blood smear, most of the time you will be able to demonstrate the asexual forms of Plasmodium falciparum, that is the trophozoites, which is exhibited in the form of ring forms. But again, here you also have to include other causes of encephalopathy. So the case fatality when you're talking about cerebral malaria is very high. 20 to 30% of cases succumb to the infection. And in patients who actually recover, there will be some form of sequelae, which can be seen in maybe approximately 5% of adults and more than 10% of children. So this is one of the most important complications which is often associated with Plasmodium falciparum. So these are again some of the pathogenesis which has been implicated in the cause of cerebral malaria. Once is because of reduced cerebral blood flow, cerebral hypoxia, and again because of the infection, there might be release of certain cytokines. And when cytokines are released, again that is the other arm of cytokines. In one way they can protect, in one way they can cause harm. So this is again one of the some of the causes, the theories which have been put forth why you have cerebral malaria in case of malaria. Then you have something which you call as the black water fever. This is because of massive intravascular hemolysis. A person or a child can present you with severe pallor, jaundice, and then a person, if you ask the history, a mother will say that my child is passing a dark colored urine, which can be because of hemoglobinuria. So most of the time you might you can have associated acute renal failure. So this is the history you have to remember. Sometimes you might have a child presenting to you with he might be unconscious, or he might present you with anemia and then jaundice. And if you take a proper history, you will find, if you ask a proper history, probably the mother will be able to tell you that this child has passed this kind of urine, dark colored urine, subsequently to how his presentation is. Algid malaria, this is again associated with cold, clammy skin. You can have hypotension, cyanosis, and a very thready pulse, which is again one of the complications which you see in case of severe Plasmodium falciparum infection. So most of the time this has got not a very good prognostic indicator if a person goes into algid malaria. Now, along with those complications, severe malaria and severe anemia, this is again one of the most common entity which is associated with malaria, because if you know that these are parasites which affects the RBCs, and RBCs, we have a lot of hemoglobin. So if all the RBCs are infected with so much parasites, definitely the outcome will be that hemoglobin which is there is actually not being used optimum, so the child or person can present you with severe anemia. And most of the time, if a person comes with this kind of severe anemia, urgent transfusion is usually required. Hypoglycemia, when the blood sugar is less than 2.5 millimoles per liter. So this can be because of so many combinations. It can be either because the parasite will consume glucose which is there in the RBCs, or maybe because of cytokines which are released, or sometimes because of treatment. It can be because of Khryiem stimulated hyperinsulinemia. So there are many other factors which are associated with hypoglycemia. So most of the times you can see that a person can present with convulsions or decrease or deterioration in the level of consciousness. Metabolic acidosis. Now this again can be one of the associated sign and presentation of during the course of the complications of if a child is or person is untreated, then this can also be one of the causes or how the disease present. They can present you with metabolic acidosis. Acute renal failure. This is usually seen in case of unstable malaria, where a person can present to you with sample complications, but the outcome will be sometimes you will find that the person presents I'm not been passing, a child has not been passing urine for so many days, or they're passing very less urine. So in those kind of cases, you have to look at you have to take a very good history and find out what is the actual cause. Because you have to rule out other causes of acute renal failure. So this is about the history, the life cycle of the parasite, the cycle, and then along with that the associated features, the complications associated more often with Plasmodium falciparum. Subsequent class, I think you'll be told about the how to diagnose cases of malaria. But please remember, malaria is one of the infections, though in spite being one of the oldest diseases, we are still not able to, probably we are going to eradicate it at some time, but we are still not be able to eradicate it, as unlike what you see in case of other infections, which most of you are well aware now what are the infections which we have eradicated. So probably in the pipeline, the next few years, we should be able to eradicate malaria, because I think we have only few subsets in the whole world where we have to deal with malaria. But all said and done, this is again a very important chapter. Please read this chapter. We are not done with it. Okay, we are still fighting against eradication for this parasite. So please read about this chapter. It's a very important chapter, not only from microbiology point of view, but you might come across cases, people of you who are going to take up other specialities. Please remember, malaria is still an entity, and if in India we still have cases of malaria, not as frequently, but you do have cases of malaria. So you have to familiarize yourself with this infection so that you are able to give optimum care to the patient who presents to you in emergency or maybe in the OPD setup. Okay, thank you.